guys, and welcome to this video where we're looking at additional ventilator settings and where you find them and how you set them up and why you might want to do so. As ever, we're ventilating a 10 kilo child who is 77 centimeters, and we're currently on pressure support, on pressure control SIMV. Right, so these additional settings are on this tab here. So if you press that button, all the vent settings, or if you click on the mode up there, then you get the ventilator settings up here. So along the top you have the modes. Down the side you have two tabs, one for the basic settings, we've looked at these already, and the other one for the additional settings. Now, just looking at the screen, I know that the majority of the additional settings that I'm going to talk about, and I think there's about 7 or 8 of them, are already in play. So I see VG here, which stands for volume guarantee, and you find that in pressure modes. I see ATC, which is automatic tube compensation, and I also know it's involved because you've got this blue line across the top. I see sigh, which tells me that there's a sigh breath is also engaged. I come down here, I see apnea ventilation. So at the moment though, I can see that apnea ventilation is off. And I've also got this PS, and PS tells me that pressure support has been engaged. So I'll just mention pressure support because I haven't said anything about that so far. We know that pediatric patients in particular like synchronous modes. They like to be able to take a breath themselves. So if a pediatric patient wants to take a breath itself, the breath needs to be supported. And the way we support these breaths are, one, synchronizing the mandatory breaths, and where you can't synchronize a mandatory breath, you add pressure support to the child's own breath, so the child can trigger a pressure supported breath. Now I'm going to talk a lot more about this in the next video actually, but just know that if you do raise this above 0, you'll get this PS sign here that tells you that pressure support has been engaged. Right, now the additional settings, the other additional settings we're looking at today are under that additional settings tab. If you click it at first, you just get an overview, and what that overview does, it just tells you of all the various additional settings that are available and what their current status is. But you need to go into them one at a time to actually see how things are set up, and that's exactly what we're going to do. So the first thing we're going to do is open apnea ventilation. So what is apnea ventilation? Apnea ventilation is a safety feature on the ventilator for children usually that you're weaning. So these children will either be on pressure support with no rate or will be on very, very, very low rates. It is based on the apnea time. So what it does, instead of it provides a backup for when the patient stops breathing or becomes apneic. So I've just switched it on. So switching this on, what will happen here is that if this patient becomes apneic, the patient will receive this tidal volume, which is exactly the same as the tidal volume he's receiving now. And it's only exactly the same because it's set up in the background when you put the weight in. So if this patient was receiving a lot more, you might need to change this value. And he will get that tidal volume at this rate. And like I said, both of these are set up in the background, but you can change them both. When you switch it on there, what happens is you can see apnea ventilation at the moment was off. Well, it should be on now because I've switched it on. So that should turn to on. I don't know why it hasn't. Maybe that's just a problem with on real vents it does. On the simulator, clearly it hasn't done so. So I've switched that on. So if this child became apneic, you would get a rate of 30 with a tidal volume of 50 mils. Now, how long does he need to be apneic for this to kick in? Well, that's set in the alarm limits. So the alarm limits you've set an apnea time of 15 seconds. So if this baby was on a very slow rate, and he didn't breathe for 15 seconds, then apnea ventilation would kick in. Don't believe me? Let's try it out. Let's just put him on pressure support where there's absolutely no rate at all and see what happens. So we drop this so we can see. So you can see there's no breaths there at all. So there's no spontaneous breath, and there are no mandatory breaths to be set here. So therefore now it's alarm. So first alarm is a yellow alarm to say this patient has gone into apnea ventilation. The second thing that's happened is telling you that its minute volume has obviously dropped because it wasn't breathing. And now the patient is not being ventilated on spontaneous CPAP pressure support. What's happened, he's getting a tide volume of 50 at a rate of 30, because that's exactly what we set in the background. So this is what the patient's actually getting now. So getting, there we go, here, apnea ventilation. So this is what this patient's getting. So because he's getting that ventilation, the minute volume alarm that was here previously that was red has gone away because the patient's now being ventilated. But the ventilator is still flashing at us, telling us there's something wrong. I'm in emergency mode. You need to do something. So what you then need to do is come back and decide, okay, this patient isn't ready for CPAP yet, or maybe he's over sedated, needs something doing to him. But you need to agree that that's the problem and do something about it. And once you actually change it, the alarm can go away. Yep. So if it's continually yellow, it means it's an active ventilation and you haven't done anything about it. You need to do something. And now that I've solved the problem, the alarm has disappeared on its own. I could reset this alarm now and it would disappear. Right, so that's apnea ventilation for you, and that's how it works. Next, we'll move on to the next additional setting, and that is the trigger. Now, the trigger is on by default. So when you switch the ventilator on, a trigger is put on by default. So what is a trigger? So a trigger is what starts inspiration. So triggers can be triggered by time. So inspiration can be triggered by time, which means the ventilator is actually doing the triggering. Or it can be triggered by pressure or flow. So patient triggers are usually pressure or flow triggers, and the most common trigger in ventilators these days is a flow trigger, and that's because it's far more sensitive. So when you set up the ventilator, put the child's weight in and turn it on, this trigger would have been set up in the background automatically. This trigger is set in liters per minute. So in other words, the patient has to initiate a breath at a flow rate of 1 liter per minute to be able to access either a pressure supported breath or a mandatory breath, which can also be triggered, which you find in synchronous mode. So if you've got an assist control mode or an SIMV mode such as this, the baby can actually trigger any of those kind of mandatory breaths. If the trigger setting is too low, there's a risk of the patient auto-triggering, which means the baby gets a breath he didn't ask for. That can also happen if there's problem with rain out or fluid in the ventilator circuit. So if you notice auto-triggering, usually you get quite a few breaths at the same time. And the baby will be quite upset by it. You need to look at the sensitivity of the flow trigger and whether or not you need to increase it. The other thing that can happen is the baby might try to get a breath and can't get one, and that's because this is set too high. And if that happens, the baby struggles to actually get a breath out of the ventilator, and then you need to examine the baby and diagnose that and make a decision to change the flow trigger setting. Usually it's set at 1 for children. It's about anything down to 0.2 in very, very small neonates, and it's set to 2 in adults. So those would be the default settings. But yes, this is on by default, so if you didn't do anything about it, it would be there anyway. So let's move on to the next setting, and that's the sigh breath. Right, what is a sigh breath? Sigh breath is a deliberate increase in tidal volume for one or more breaths at regular intervals. Why would you want to do that? So in the 70s, all ventilators had a sigh breath mode, and then they kind of disappeared in the 90s and noughties, but they've made a big return now. So most new vents are including some sort of sigh function. So what a sigh is a breath that's bigger than all the others, and the idea is that if you take a breath that's bigger than all the others, you'll stop alveoli at the periphery collapsing. We subconsciously take a sigh breath. Some people say every 6 to 8 minutes, one sigh breath. But if you're on a ventilator, you get the same breath every time. So it's been thought that patients who have low tidal volume ventilation, so especially those who have an ARDS or small white lung kind of scenario, they would benefit from sigh breath. And there's quite a body of evidence now that's developing that's saying we should use sigh breaths in these patients. And also patients that are self-ventilating for quite a long time on something like CPAP ASB, they're at risk of peripheral alveoli collapsing, and as such would benefit from an increased breath. Now, the way sighs are delivered with this ventilator is you get an increase of PEEP, and you set that PEEP in here, so you can hear the default is you get an increase in PEEP of 5 for this number of breaths. So in other words, this patient will have 3 breaths where the PEEP goes not at 5 but at 10, so you get this 5 plus that 5. So normally the PEEP is 5. For 3 breaths, this patient's going to have a PEEP of 10, so it's going to get this additional 5 to it. And he's going to that's going to happen to him once every minute. So what does that look like? One's happening now, but I'll show you what it looks like on the next one. So once it's switched on, so like I mentioned, you can actually see that the sigh is switched on. The level of PEEP you can use can be quite significant. So in ARDS in adults, they use PEEPs which push the plateau pressure up to something like 45. So they'd normally be on high PEEP anyway. So they can add 10 or 15 to that, but the peak the plateau pressure shouldn't be more than 45 when they add that. And they can do that several times a minute. Most of the time people use 3 breaths at a time. And that kind of seems to work for them. So we're just waiting for the PEEP to double here, and you'll see it will go up for 3 breaths. So, okay, here we go now. So you can see the PEEP has increased, PEEP has increased, PEEP has increased for 3 breaths, and then it's gone back down again. So that's exactly what a sigh breath looks like, and that's going to happen once every minute. So there isn't enough evidence at the moment to say that we should do it for everyone all the time, but I think on a case-by-case basis, it's one of the things we should be looking at. Right, next on the list, we have a volume guarantee. So volume guarantees are the sort of thing you only find in a pressure mode. And it's in most pressure modes, but not all of them. You don't get it in BiPAP, you don't get it on APRV. What it is, in a sense, is saying that it's about guaranteeing a volume at whatever PIP you've selected. So the problem with pressure ventilation is that the tidal volume varies with the patient and with obstruction to the tube and secretions and things like that. So for ventilatory purposes, we would love the volume to remain stable, and you can now do this in pressure ventilation. So what you set is the tidal volume you want, and you also set the pressure you don't actually want it to go above. So what the ventilator will do, it will try and give you this tidal volume. Well, it will give you this tidal volume all the time, and it will try not to go above that pressure. So in reality, sometimes though, if the chest actually becomes very poorly compliant, it will exceed that pressure, but then it will alarm, it will tell you that the volume's inconstant, and then you'll have to decide whether you want to do something about that tidal volume or something about that inspiratory pressure, or whether you want to do something else with the patient to make this work. So it's a good thing. It's relatively new, but I think there's a slightly better way of doing that, and I'll talk to you about that shortly. That's called AutoFlow, and we'll talk about that shortly. Right, so the last thing on this tab here is the automatic tube compensation. Now, what is that? So the ET tube presents a problem. Well, it's wonderful in that we can actually ventilate people through it, but it's small, narrow, and long, so the diameter or radius isn't very big, so therefore it adds a significant amount of resistance to the airway, so it increases airway resistance. And increases airway resistance to the extent that the pressure at the beginning of the tube is higher than the pressure at the end of the tube in the trachea. So the pressure that you set, or PEEP, or the pressure that's generated that the ventilator displays to you, is actually lower. So it's a lot lower in the trachea than it is at the top of the ET tube. So it might be that we want to compensate for that, and indeed we do. So especially as you're starting to wean patients and you're expecting patients to take over the breathing themselves so that we can get them towards extubation, it becomes very important for us to take the work of breathing associated with the ET tube into consideration. So one way of doing that is by putting on automatic tube compensation. So what you do is first you switch it on, you then tell the patient, tell the ventilator whether it's an ET tube or a tracheal tube. You then tell them what size tube they're actually going, the patient has in, and you tell them how much you want them to compensate for. So you want, most of the time you want 100%, but sometimes not always. Sometimes you want the patient to actually do a bit of work, and therefore you can reduce the amount of compensation that you can reduce the amount you compensate for. Now you can do it in just inspiration or just expiration, but you can't choose that here. That's chosen in the system setup. So therefore you can tell it's on, but you can't necessarily change it. You have to go in here and there's a code, and then you have to know where to find it, which is actually not straightforward. Your ventilator technician can do it, but that wouldn't be something for you. So this is one way of compensating for the resistance in the tube. The other way is doing what we do most of the time. So if you allow me to go back to CPAP ASB, this is what we normally do with our spontaneous breathing trial. So instead of using automatic tube compensation, what you can do is just make sure that there's a pressure support of at least 5 and a PEEP of at least 5 to overcome the resistance that we think is happening in the tube. So that's the other way of doing it. So that's the traditional way of doing it, but it's nice to know that there's a way to do it in the ventilator. And as I mentioned earlier, once, let me kill that alarm. Once it's on, you can see this blue line. So effectively what you're looking at, the actual waveform, the solid blue bit, is the pressure that the ventilator is providing. The blue line is the pressure that the ventilator would have been provided if you had not turned the tube compensation on. So in other words, the solid blue bit is telling you I'm actually giving you more pressure, and this line tells you how much the old pressure was and where the old pressure was being given. So it's a nice little reminder that one, you switched it on, and it is trying to tell you where it's actually trying to help out. So there's a couple of other additional settings, but you won't find them in pressure control SIMV. So for the first one, we have to go to volume control SIMV to find, or any volume control mode to find it out. And here you'll find what we call AutoFlow. So I'd already switched it on previously, and therefore you can see that it's actually switched on here. So this is volume control SIMV with AutoFlow. So what is AutoFlow? AutoFlow is a method how we give a pressure style breath in a volume mode. So what does that mean in plain English? In plain English, it means that you set a tidal volume, but instead of getting what you would normally get for volume, which is a continuous flow style breath, you get a decelerating flow breath. So we've set volume, but you can clearly see that this is a decelerating flow breath. Now, what would be the point in that? The point in that is, one, to try and keep pressure, or your peak inspiratory pressure, to a minimum. So it's a way of reducing the peak inspiratory pressure while guaranteeing the volume. So that's the sort of thing you want to do, especially in things like ARDS, where peak pressures will lend itself to cause more volume trauma. So that obviously we're trying to avoid. But so there you've got a pressure style breath, but the volume is guaranteed at the same time. So although the volume is guaranteed, and it will be, the pressure will vary. So therefore, at the moment, you've got a PEEP of 11, which is quite low because this is a patient with normal lungs. But if this was a patient with small white lungs and you were trying to give that patient a tidal volume of 50, you'd find that the peak inspiratory pressure would rise. And as the compliance got worse, it would get higher and higher and higher. So you have to have a way of saying, right, ventilate this patient with this tidal volume. I don't really mind what the pressure is or what the peak inspiratory pressure is, but I do not want it to go above a certain limit. So the limit that is set with AutoFlow, or pressure regulated volume control, which is the alternative name for this mode of ventilation, is 5 below the maximum airway pressure. So your maximum airway pressure is set by this red line here. 5 below that will be the maximum pressure that you could go with AutoFlow. So if you'd set this and the lungs were getting worse and the PEEP went up and it reached 25 and beyond, it would start to alarm yellow here, and it would say volume in constant. And what that would mean is that you need to change your parameters, or bail out and do something else. I don't know, start nitric, put him on the oscillator, turn him prone, whatever you have going for you. But you need to do something. You can't just can't leave it as it is. You could decide that, okay, 25 is not too high, I can allow it to go to 30, in which case what you would do is change the alarm limit. So this is your maximum pressure here, which is 30. So if you wanted to allow AutoFlow up to 30, you would need to increase this to 35, because remember, it's like 5 below. There you go, 34. So you could get it up to 29 with this, and you can see that the line has actually moved up as well. So that's what you get with AutoFlow. So it's with any volume mode. Personally, I think if you decide to volume ventilate any patient, you should just switch it on. And it's great for when patients are getting worse. It's great for keeping CO2 the same. It's great because it will deliver the volume you've set here at the lowest possible pressure. And I did point out earlier that most volume modes have a flow button. once you engage AutoFlow, the flow button disappears. So you have no say over the flow because the volume, because the ventilator has taken that over. So it's similar to volume guarantee, and it's a very useful mode. Now there's one other additional setting that I was going to show you, but you only find that in CPAP ASB, which is one of the spontaneous modes where we just set CPAP. And that's this one, Smart Care. So Smart Care is the sort of ventilation that puts doctors out of business. What it does, it knows what all the volumes are, and the end tidal CO2 needs to be fed into it. So it knows what the end tidal is, it knows what the FiO2 is, and then based on that, it decides how much pressure this patient needs. There's good evidence for its use in adults. There's no evidence for its use in children, so therefore I tend not to talk too much about it. So that's there. As you can see now, because I've put him in CPAP ASB and he's got no backup rate, patient's automatically gone back into apnea ventilation. So I'm going to need to change that back quickly before it starts alarming. There you go. So now it's all switched itself off. Right, so that's all I've got for you today on this one. So basically we've looked through all the things that you can find on the additional settings tabs, where you can find them, and how you can know by just looking at the screen which ones are switched on or not. I hope you enjoyed it. I hope to see you on the next one, where we'll be talking about modes of ventilation. Thanks a lot. Bye.